So we've looked at hemorrhagic and ischemic strokes and how they present. Now let's look at how we manage these patients medically. Now this stuff is pretty cool, guys, and I think you're going to like it. I think you're really going to love this stuff. It's actually pretty exciting to look at this and how we manage this because I think it makes a lot of things really come together. So let's go ahead and dive in. So first of all, with ischemic strokes, our major goal with ischemic stroke is two things. One is to ensure perfusion to the brain tissue. The other is to get rid of the clot. So we got to get rid of that clot and we got to get blood flowing again. Now, there's a couple ways we can do this. One of these things is permissive hypertension. This means we allow their blood pressure to be way higher than we normally would, possibly even into the 200s. Now, if you remember from the cerebral perfusion pressure lesson, mean arterial pressure, or MAP, minus ICP equals CPP, cerebral perfusion pressure. Now, the higher the MAP, let's put that over here. The higher the MAP, the higher our CPP is going to be. So if you think about this, we have limited blood flow, right? We have limited blood flow going on. So what we want to do is we want to get these vessels squeezing harder and run that blood pressure up to try to push it all through that clot so that they can keep getting, let's say our brain's all over here, they can keep getting blood into the brain, right? We don't want to stop that blood flow. If we stop that blood flow, we got 10 minutes until we have complete death. So we let this blood pressure run up, let it get into the 200s, possibly, so that blood keeps squeezing through these vessels and going to this patient's brain. Now, another thing we can do is antithrombotic therapy. This would be things like TPA, or it's called alteplase. Now, what this medication does, it actually goes in and it busts up this clot and it opens up the vessel. Now, just keep in mind, when it busts up this clot, it's going to bust every clot in the body, okay? It's antithrombotic. And so our patients become at this very high risk of bleeding. So if a patient gets TPA, man, we got to keep that patient in bed. They are not getting out of bed. And one couple of things we're doing is we're checking for bleeding. We're checking if they have, and you will see this, if a patient has IVs, you're going to see a lot more blood coming out of the IV. If they have a catheter, you're going to be checking for blood in the cath bag, okay? If they have any chest tubes or if they have any lines, you're going to be checking for blood coming out of those. We really want to make sure we don't lose blood, because the goal of this really is just to bust this clot up and get blood flow restored to the brain. Now, we also have a couple surgical options. One is a carotid endarterectomy, which we talked about in the cardiac lesson, and percutaneous thrombectomy, which is where they actually go in through the arteries to clear out the clot. This is really fun to watch. If you ever get to go to the cath lab, or you ever get to see like an interventional neurologist, what they do is actually go in through the femoral artery and they feed a line. Think about this. They go into the femoral artery and they feed a line all the way up into the brain. And it's got a little catcher on it, and it goes in there and it whoop, scoops up this clot, and then they pull it all the way out. Boom. And you can actually then see the little clot that was causing it. But that's so cool. Like they do it over like interventionally, and you can go in and you can actually watch this like TV screen where they're going in there. And as a nurse, sometimes you might get a chance to work down there. If you ever get to like work in neuro ICU, you might get a chance to go down there and actually help with these procedures. It's really cool to be there. And it's really cool to watch. Now, of course, when these patients are discharged home, they need to be on statin medication, and this is going to decrease plaque buildup. Okay, we're going to try to keep plaque low. We're going to try to keep their cholesterol low within their arteries so they don't get another clot, right? We already know they're at risk. They've already had one. We're going to try to prevent any more from happening. Now, when it comes to hemorrhagic strokes, treatment options will vary based on the source of the bleeding. If it's an aneurysm, we can either clip or we can coil. Now, these are really cool, and we're going to talk about this with these hemorrhagic strokes, okay? So with these hemorrhagic strokes, let's say here's our artery. We have like this aneurysm, right? We've talked about aneurysms in a couple other lessons. We have kind of this aneurysm or this kind of outpouching. Now, in this image, we can see the outpouching of the vessel here in the aneurysm. So in coiling, what the doctor does is they'll actually enter through the carotid artery, go into the aneurysm, and insert little coils of wire into that outpouching. So they actually feed the wire up in here all the way there, and they actually put all these little coils in there. So this is a pretty common way that they do this, and these coils just kind of eat up this or go into that outpouching there. So what will happen is that aneurysm will clot off, so blood can't flow into the weakened part of the vessel. So what happens is we have these weakened heads of these aneurysms. When you get all that coiling in there, it kind of makes it all clot off, and blood can't come up in here and burst this weakened head and create another stroke. Now, we can also clip the aneurysm. What happens here is a neurosurgeon will actually go in externally and place an actual clip right here on this part of the aneurysm, right where it pouches out from the vessel. And that's also going to prevent the weakened part of this aneurysm from bursting. Now, we can also do what's called an open craniotomy or an external ventricular drain. Like we talked about in the ICP lesson, we're going to try to drain some of that blood off. Let's pretend like this is a head, mouth. So we're going to try to drain some of that blood out and restore that brain tissue. So you're going to see external ventricular drains. You're going to see them called as EVDs or Ventric. We talked about this a little bit more in our ICP lesson, but an important thing to understand, you're going to need to know them if you work like neuro ICU or even just ICU. Be important to know. One thing we have to manage with our hemorrhagic strokes is something called vasospasm. Okay, vasospasm. I want you to know this. Not only is it going to impress your professors and impress the providers you work with, the nurses you work with, it's also important to know. It's also something that really can happen to your patients, and you need to be able to watch it. So to prevent vasospasms, we can do something that's called triple H therapy. That stands for hypertension, hypervolemia, and hemodilution. So what we do is we give these patients lots of fluids to increase their blood pressure, and we try to fill these vessels up with fluid to keep them from spasming. Remember, we talked about before, they're going to lose all this fluid, and that fluid is going to touch all these nerves, right? And then that can create this spasming of these vessels. And so these will just start spasming. That can be lethal to our patient. So what we're going to do is we're going to pump them with a bunch of fluid after we've clipped or coiled, and we're going to run their blood pressure up, and that's going to help to prevent vasospasming. So one thing you can do is you can say, hey, why are we running up the blood pressure on a patient who just had a hemorrhagic stroke, who's bleeding? Well, that's why. It's called triple H therapy. All right. The other thing we do is we give medication. The main medication we're going to give is called nimodipine or Nemotop. Now, this is a calcium channel blocker that acts directly on the vessels in the brain to relax the smooth muscle and prevent vasospasms. So we're going to give them both of these therapies. They're going to be on fluids. We're going to let their blood pressure go up a little bit. We're going to put them on nimodipine or Nemotop. And this is one of the most important medications that we can give to a patient who's had a hemorrhagic stroke. So we said multiple times now that treatment for stroke needs to happen fast. But what does this actually look like in real time? Okay, well, the American Stroke Association has actually set goals on what the timeline should be like once a patient presents with stroke symptoms. Now, we want them to see a physician within 10 minutes, specifically a neurologist who can do a detailed assessment and an NIH stroke scale that we've talked about. The other thing that we need to know is, when was their last known normal? So we want to know, when did they last act like themselves? This is going to impact the treatment that they qualify for. If they woke up with symptoms, then their last known normal was whenever they went to bed. And so with a lot of these patients, that's kind of the last thing we know. They went to bed fine, everything was fine, we just had dinner, everything was fine. And so that last known normal can get pushed back and farther and farther. So what we'll do is we'll activate the stroke team and get the patient to CT scan right away, with the goal of having the CT read by a radiologist within 45 minutes. All right. The ultimate goal is for this timeline is to be able to give them antithrombotic medication within just 60 minutes of presentation. Now, patients whose symptoms began more than 4.5 hours ago, keep that in mind, 4.5 hours, who have an obvious bleed on the CT, do not qualify for TPA. We can't give them TPA if it's been more than 4.5 hours, which sadly a lot of times it can be, or they're having a hemorrhagic stroke. All right. Now, the studies show that the sooner they receive it, the higher their chance of full recovery. So most hospitals have a system and teams in place to make this process happen really quickly. One of the facilities I work at with had an average time of 47 minutes door to TPA. Now, a lot of systems have to be in place to make that happen, but that's the goal, is getting these patients treated as quickly as we can. Now, I know this says door to physician, door to CT, etc., but we're really talking about the moment they present with symptoms. Now, that's when the clock starts. Even if they've already in on the hospital, okay, we have to get that going as fast as we can. All right, so let's remember our goal with therapy for ischemic stroke is to remove the clot, either with clot busting medication or surgically. All right, for hemorrhagic stroke, our main goal is to stop the bleeding. All right, we can do that through coiling, clipping, or craniotomy. And then remember, we have a timeline for these goals of therapy, so we need to act fast and get help as quickly as possible because time is tissue. We got to save brain tissue, okay? And we got to save as much of it as we can. All right, guys, this is so much fun. I love this stuff. I hope you guys enjoyed this lesson. I hope you guys learned a few things. Now, I want you to make sure you look through all the other lessons with stroke here in the neuro course. And then I want to make sure you do the case studies and the care plans, look over all those, do some questions, because you really need to understand this. If you have to understand one disease process in neuro, this is really one that you need to understand. All right, guys. Now I want you to go out and be your best selves today. Happy nursing.